most of you on this call, but for those who I haven't had a chance to meet, I'm Jared. I'm one of the third year residents, and I'm going to be doing a talk on point of care ultrasound specifically and how we can integrate point of care ultrasound into our diagnostic assessment of lung and heart pathologies. I don't have any disclosures, but just want to give a big shout out to Dr. Amanda Shepard. I was lucky enough to take the POCUS elective at the end of my second year, and was really able to learn and kind of advance my skills. And a lot of this talk is adapted from what Dr. Shepard taught us. So, a big shout out to her. I'm certainly not a POCUS expert, and it's still something I think I'm early in my stages of learning, but as part of this elective was able to learn a lot of new skills that I didn't have before. And so hoping to give a brief overview of some of those and kind of encourage you guys to practice when you're back on the wards or in the ICU. So, objectives of our talk today, we'll first just very briefly review some basic ultrasound terms and the difference between B and M mode ultrasound, which will be pertinent in our later discussions. We'll then talk about the modified blue protocol and kind of the diagnostic utility of lung ultrasound, and then briefly review some of the basics of cardiac point of care ultrasound and learn about some methods to obtain objective measures of cardiac function as opposed to just saying squeeze looks good or squeeze doesn't look good. So, briefly reviewing the basics, this will probably be a review for those of you who have ultrasound experience, but for those who don't, it'll be helpful in informing our discussions down the road. Firstly, just some terms that I'll use. So, ultrasound is a sound wave, and essentially what we're seeing is the degree of ultrasound wave reflections from the different structures in the body. And so, when talking about ultrasound, kind of brighter structures we'll decide as hyperechoic, kind of less bright we'll describe as hypoechoic, and then anechoic is kind of no echo reflection. And so what that means for us is for those of you who have used an ultrasound before, we're able to adjust the gain or kind of the amplification or sensitivity of the returning sound waves. And we should always try to adjust the gain. So kind of simple fluid, which you can see here is anechoic. And then structures like the pleura or bone will be hyperechoic or bright. And then kind of other structures are delineated in different shades of gray. So there's a lot of different ultrasound modes that you can use. The two we're going to talk the most about are first is B mode. And I won't go too much into that, but that's essentially just the normal ultrasound that you use. When you turn on the ultrasound and you can adjust the brightness, that's B mode. The second modality, which maybe not everyone has experience with, is called M or motion mode. And what this allows us to do is get a kind of time motion display of a specific line of ultrasound over time. This is a brief video that shows that you can essentially just hit M mode. You place a line of where you want to see those structures over time, and then you activate it, and then it essentially just shows you a graph of those structures over time. This is looking at the anterior mitral valve leaflet, which we'll talk about towards the end of the talk. But you can see this line here is just the movement of that mitral valve leaflet over the period of time. So that's M mode, just so when we talk about that, you're aware. And so next, we're going to move into lung ultrasound and talk about something that I call the modified blue protocol, which I got from Dr. Shepard, and how we can use that to kind of add to our diagnostic reasoning when we're evaluating someone with a concern for a lung pathology. So this is based off a protocol that was developed based off a decision tree in evaluating a patient with acute dyspnea. This is like a complex graphic, and you can see there's a lot of different things that need to be done, and eventually it leads you to kind of the expected diagnosis. I think, this includes like evaluation of the veins and things like that. And I think in kind of the acute clinical sense, it's a little bit less useful kind of going through this full blue protocol. So instead, I'm going to walk you through what I was taught is the modified blue protocol. And this is a quick exam. You can do it in usually 5 minutes or less with a little bit of practice. And we're just looking at 8 different spots on the body, 4 on each side. We'll kind of start off looking at the midclavicular line in the second intercostal space. We'll move down 2 rib spaces to the fourth intercostal space. We'll go a little more lateral and look at the mid-axillary line in the sixth and seventh intercostal space. And then we'll finish up at the PLAPS point, and I'll talk about that more in depth lately. Dr. Shepard taught us this kind of eight point modified blue protocol. Some other literature online uses just a six, three on each side. And I think this is a helpful graphic representation of, using these 3 points, you're able to, on the right lung, look at all three lobes of the right lung. When you're up top and more medial, you'll get the right upper lobe. As you move down and more lateral, you'll get the right middle lobe. And then and kind of towards the end, you'll get that costophrenic angle in the right lower lobe. And so that's where we look. And the next question is, what are we going to be looking for? So we'll walk through each of these individually, but essentially we'll first talk about lung sliding, then we'll talk about A lines versus B lines. We'll talk about specific signs of consolidations that you can see on point of care ultrasound, and then we'll talk about looking for effusions. So to orient ourselves for some of the images we're going to be seeing later, this is kind of the general view of looking at the lungs with an ultrasound. It's sometimes called the bat wing sign. So essentially, you'll put your ultrasound probe in between two ribs. And so the ribs will not allow transmission of the ultrasound beams. And so you'll get kind of rib shadows behind. You'll see the subcutaneous tissue up top. And then you'll see this bright line is the pleural line, and then everything below is the lung tissue. And so all of the images we'll see after this will kind of have a similar orientation. So just so you're aware of kind of what we're looking at as we go through this. So the first thing we're going to look for is lung sliding. So lung sliding is we are specifically looking at this pleural lining here, this bright hypoechoic structure. And lung sliding is a normal finding. So you can think the two layers of the visceral and parietal pleura are abutting one another. And with the respiratory cycle, they're sliding back and forth as the patient breathes. And this gives what's called this kind of shimmery, or sometimes called an ants on a log appearance. And again, like I said, this is a normal finding. This means the visceral and parietal pleura are abutting one another. Um, the pleural level is pretty shallow. So usually I'll start off with a linear probe because you'll get some better definition and you don't need to look too deep. And it can help you see that lung sliding more effectively. Sometimes it can be a little bit unclear. And so in that situation, you can use M mode. So you essentially would just put the mode line here down the middle, activate M mode, and you'll see what's described as kind of a sandy beach appearance. The sky in this image is the skin and subcutaneous tissue up here. The ocean is this muscular tissue. And then the beach itself is made by the lung sliding motion. So that ants on a log appearance of the visceral and parietal pleura moving against each other. And so, like I said, lung sliding is a normal finding. And so if lung sliding is present, you can rule out a pneumothorax with 100% sensitivity in the area that you're looking. I think it's important that if lung sliding is absent, it doesn't necessarily mean that there is a pneumothorax. There's some other confounders that can cause that. But if you do see lung sliding, you can be reassured that there's not a pneumothorax there because those two layers of pleura are abutting each other and there's not air in between. So then the next question is what happens if there isn't lung sliding? And so this is an example of absent lung sliding here. So if I quickly go back, you can see this kind of shiny ants on a log appearance. Whereas here, there's none of that. There's kind of just this single line of pleura and none of those two layers of pleura moving against one another. And so what this means is that the parietal and visceral pleura have become separated. I think we most commonly think of this as pneumothorax. There's air in between those two layers of pleura, but there can be some other process as well, whether it's fluid or whether a patient had a pleurodesis in the past. And sometimes in severe fibrotic lung disease, you'll just lose the lung sliding. Again, sometimes it can be a little bit difficult to ascertain just looking at it in the B mode ultrasound. So in that situation, you can use M mode. And if there is absent lung sliding, you'll get more of this barcode appearance. And so whereas before we had this nice sandy beach, here instead we have this kind of barcode looking appearance, which is consistent with absent lung sliding. And again, this can be concerning for a pneumothorax, but isn't 100% specific for that. What is 100% specific for a pneumothorax is if you're able to identify this lung point sign. And admittedly, this is never something that I've been able to find on point of care ultrasound, but it is something that is possible. And it's essentially the transition point of the pneumothorax. So what the lung point is this point where you can see on the right side of the image, you have this kind of shiny ancillary log appearance. And then on the left, you lose that lung sliding. And so there's this sudden transition point, and that is diagnostic for a pneumothorax. And so we've talked about lung sliding, and now we'll talk about A and B lines. And we often think of differentiating, is there an alveolar filling process occurring? So the normal finding is what we call A lines. You can see these kind of repeating horizontal lines. And what that is actually an artifact. So if there's kind of air in the alveoli, then the pleural line has what's called a reverberation artifact, and it just repeats in equidistant sections. And so, as I mentioned, A lines indicate that there's healthy aeration of the alveoli in most situations. The one potential confounder is in a pneumothorax, you'll still get this A-line pattern because there's air. The problem is the air is not in the alveoli; it's in between um, the two layers of the pleura. But so this is kind of reassuring that where you're looking, there's not an alveolar filling process. The inverse is what we call B lines. So what B lines look like is they're these kind of ray-like, they're hyperechoic and vertical. They emanate from the pleural line. I think it's important to note that to be called a true B line, they need to extend at least 10 centimeters. So whereas before we were using a linear probe, for the remainder of the exam, you'll be using either a cardiac or an abdominal probe, usually cardiac because it's easier to get in between the rib spaces. But they'll extend 10 centimeters. You can have up to two B lines and still call it normal because sometimes the lung fissures between the lobes can produce single B lines. But if you have three or more B lines in a single field, that is concerning for an alveolar filling process. So we can't say exactly what that alveolar filling process is. It could be, cardiogenic pulmonary edema, it could be pneumonia, or it could be alveolar hemorrhage. But we know there's some fluid in the alveoli. But then you can also use patterns of ultrasound. You're looking in these different locations as you go. So if a patient has cardiogenic pulmonary edema, let's say, then you might see bilateral diffuse B lines, and there might also be a gravity dependent pattern. Cardiogenic pulmonary edema tends to occur predominantly at the bases, and so you might see more predominant B lines at the bases. Whereas if, say, a patient has a focal lobular pneumonia, then you might only see these B lines in a single lobe, and then you'll see A lines in the remainder of the lobes. And so sometimes that pattern can kind of add to your diagnostic reasoning as you're working up a patient with a lung pathology and help inform kind of your differential diagnosis and what might be most likely. And so B lines initially will start with like a mild, moderate alveolar filling process. You'll get these thin B lines. And then as the alveolar filling process continues to progress, it'll be more difficult to differentiate between singular B lines. And so it'll appear more like this, kind of this large confluent B line. And so even though you might only see one B line here, really this is just a number of B lines that have all become confluent with one another. And so that's representative of kind of a more advanced alveolar filling process. As I mentioned before with A lines, there is potential confounders, one of which is chronic scarring. Things like fibrosis and ILD can cause B lines even without fluid accumulation. So knowing a little bit about the patient's kind of baseline lung history is helpful as you help interpret these images. So that's A lines versus B lines. And now we'll talk about specific signs of consolidations. So as fluid builds up in the alveoli, it'll transition from B lines to what's called subpleural consolidations that you can sometimes see on the point of care ultrasound. And so this is an example here on the left. You can see this kind of almost anechoic consolidation just below this pleural line. And that's what we call a subpleural consolidation. There's kind of this sign in the ultrasound literature that they use called the shred sign. And essentially that's represented by these black arrows. So you see the pleural lining here, with the white arrows, you see this subpleural consolidation, and then these black arrows along the border, like this kind of jagged echoic edge. It almost looks shredded, represent kind of the border at which that fluid-filled tissue meets the air. And again, we can't say whether that's water or pus in the alveoli, but we know there is something there. The one confounder is you can also sometimes see this with atelectasis. So it's important to kind of use some of your other clinical clues to differentiate between atelectasis for, say, a bacterial pneumonia. And then as the alveolar filling process progresses and the lung becomes completely filled with fluid or completely collapsed as an atelectasis, the lung actually starts to look like the liver. Whereas kind of before in our earlier images, you see lung tissue that looks like lung. For someone who's ultrasounded the liver before, if I didn't tell you that this was an image of the lung, you might think it looks like the liver. And that's just because it's become either completely filled or completely collapsed. And so it starts to look like this kind of more dense hypoechoic structure compared to what we were seeing with early lung tissue. So this is indicative of either a dense consolidation or complete atelectasis. And again, you need to use some of your other clinical clues to differentiate between those two, but it can provide some additional diagnostic information in a pretty short amount of time, as say you're working to admit a patient from the ED to the floors. And the final sign that you can potentially see in a consolidative process is what are called air bronchograms. And I know we often think of air bronchograms in a chest x-ray sense, and these are different, same name, but kind of different pathologies. And so it's important to keep that in mind. But essentially, what these are these kind of hyperechoic specks that you can see moving up and down in this image. And what causes these is there's trapped air in the consolidation that kind of appears as this hyperechoic speck. And so something I read, something I've never been able to appreciate myself, but these dynamic air bronchograms, which we see in the image here, tend to occur more in pneumonia. So they move as the patient inhales and exhales. Whereas something like an atelectatic process will tend to have a static air bronchogram. So this wouldn't be moving, it would just be static through the respiratory cycle. And that's because these air bubbles are completely trapped behind the kind of collapsed lung. And so the last aspect of the modified blue protocol that we'll be looking at is effusions. We've kind of gone through the first six, three on each side spots, and then we'll finish our evaluation looking at the PLAPS point. And PLAPS stands for posterior and or lateral alveolar and pleural syndrome, which doesn't make a lot of sense to me. So I just call it the PLAPS point. Where you're going to find this is going to be different in every patient. But essentially, you're looking for that costophrenic angle. So where the diaphragm starts to meet the kind of abdominal organs. Usually, where I start to look is kind of the intersection of the posterior axillary line and one of the rib spaces between the 10th and 12th ribs. And you can just kind of move up and down rib spaces to try to find the appropriate point. Say if you start at the 10th rib space, you're seeing lung tissue, you can move down until you start to see some of the abdominal organs. Say a patient has large hepatosplenomegaly, you might see it higher. If they're a small patient, or if they have COPD and hyperinflated lungs, you might see it a little bit lower. But that's usually the place that I start. And just like with chest x-rays, this costophrenic angle is the best place to look for pleural effusions because from a gravity-dependent nature, that's where it's going to accumulate. And so these images here are different examples of the PLAPS points. This is on the right side, this is on the left. And what you see is the diaphragm coming down. Below the diaphragm, you'll see either the liver or spleen, and sometimes you can see the kidney as well. And then the lung tissue is obviously above the diaphragm. You can see in this image that the lung kind of looks like the spleen, or the lung kind of looks like the liver. And that's not hepatization of the lung. When you're seeing the diaphragm, sometimes you can get some mirror artifact. So this is actually healthy lung tissue, but it just, because of an artifact, looks like the liver. And I think we'll talk about why this is important later. But I think it's important to note that you can see the spine here, but the spine seems to terminate once the lung tissue starts. That is because air does not transmit ultrasound waves well. And so once the lung tissue starts and there's this air-filled tissue, you're unable to visualize structures that are deeper to that lung tissue. So the spine seems to terminate kind of right at the level of the diaphragm. And we'll talk about why that's important later. And so these are healthy, normal looking PLAPS points. And then this is a kind of a more dynamic representation of what the PLAPS point will look at like. You can think the diaphragm is moving with the respiratory cycle. As you take a deep breath in, the diaphragm moves down and pushes some of those abdominal organs down. So you'll get what's called a curtain sign. So whereas before we see the PLAPS point, you see the diaphragm here, lung here, liver here. As the patient takes a breath, the diaphragm moves down, pushes the liver down, and kind of the lung tissue takes up the entirety of the image. And it almost looks like a curtain going over the liver. And so that's a normal, healthy finding. And so as you're looking for it, this is kind of what you'll see and what'll tell you that you're at the correct PLAPS point, because it certainly doesn't always look as pretty as the last images. And what about an abnormal PLAPS point if a patient has a pleural effusion? So these are two images that are examples of patients with pleural effusions at the PLAPS point. And so you'll see here, you'll see the diaphragm, you'll see either the liver or spleen. And whereas before there was this healthy lung tissue, now you have this kind of anechoic, simple fluid collection at the costophrenic angles, which is representative of a pleural effusion. I think it's interesting to note that ultrasound is actually more sensitive for the detection of pleural effusions than chest X-ray or CT. So even in a patient with very small pleural effusions that wouldn't be picked up on other imaging modalities, you may be able to pick it up on point-of-care ultrasound. And you can see this here kind of hanging out in the pleural effusion. We'll talk about this a little bit more, but this is essentially just collapsed lung tissue. It's atelectasis in the setting of this large surrounding pleural effusion. And there's literature out there that you are able to calculate or estimate the volume of a pleural effusion by calculating the maximal effusion diameter from the diaphragm to the base of the lung in a supine patient and multiply it by 20. Admittedly, this isn't something I've ever done in my clinical practice. I usually just kind of qualify it whether it looks mild, moderate, or severe based off the general appearance of it. But it is something that is some data out there to do and might be something you can track as, say, you're diuresing a patient if it's from cardiogenic pulmonary edema. The point of care ultrasound literature loves to talk about different signs. And so these are two signs that can be that you'll hear when thinking about pleural effusion. The first is the spine sign. So as we mentioned before, in a healthy patient with no pleural effusion, the spine seems to terminate at that border of the diaphragm because the healthy lung tissue isn't transmitting the ultrasound waves. But if they all of a sudden have this pleural effusion, which is able to transmit the ultrasound waves well, then you'll start to be able to see the spine above the diaphragmatic border. So you can see on the image on the left, whereas before the spine would terminate right around here if there was no pleural effusion. In this patient, you can kind of see the spine extending all the way up past that costophrenic angle. And then this is a kind of another fun named sign called the jellyfish sign. And essentially what this just represents is this is the collapsed lung tissue, atelectasis in the setting of this surrounding pleural effusion. And it kind of looks like a jellyfish waving in that pleural effusion. Point of care ultrasound can also help you start to differentiate between whether it's a transudative or exudative pleural effusion. And there's this sign called the plankton sign, where it's these kind of swirling hyperechoic debris in the pleural effusion. And this can be representative or more suggestive of an exudative pleural effusion. Obviously, you would need to sample the tissue and kind of look at Light's criteria or the PFO3 criteria to confirm that. But this could give you an early hint before you're able to get a sample that this might be an exudative as opposed to a purely transudative effusion. You can see in the last image, it's kind of this simple anechoic fluid collection. But here you have this kind of swirling hyperechoic debris, which can occur in exudative effusions. It can also help you to visualize loculated pleural effusion, sometimes something you might not get on just a simple chest X-ray plain film. You can see here there's these kind of loculations stranding in the pleural effusion. which is suggestive of a loculated pleural effusion, and might help inform your management before you're able to get a thoracentesis sample. So that is the modified blue criteria. We talked about lung sliding. We talked about A lines versus B lines. We talked about signs of consolidation and then looking at pleural effusions. And again, none of these are 100% diagnostic for any single process, but it's really the pattern of findings that you find over your exam that can help to suggest a potential pathology. This is kind of a table I made where I think of some different things that you might see and that might push me in one direction or another when I'm thinking about what the diagnosis for my patient is. We talked about in a pneumothorax, you'll see absent lung sliding. And then if you see that lung point slide, that sign that would be diagnostic for a pneumothorax. When you're looking at M mode, it would look like a barcode as opposed to that sandy beach. And then you'll still see bilateral A lines, even at the side of the pneumothorax, because there's air there. It's just either air in the lungs or air between those pleural linings. With a pneumonia, you might see a consolidation or a hepatization of the lung. You can see that shred sign in the subpleural consolidations. You'd see B lines in the area where the pneumonia is. Obviously, depending on whether it's a kind of focal pneumonia or a multifocal pneumonia, it would be unilateral or bilateral. But kind of that distribution can help inform you as you're thinking about the potential diagnosis for your patient. Sometimes you can see reduced lung sliding just from the inflammation and kind of subsequent inflammation of the pleural lining. You might see dynamic air bronchograms, and you might see something like a unilateral small parapneumatic effusion. If a patient has cardiogenic pulmonary edema, as opposed to a more focal B-line pattern, you'll see widespread and bilateral B-lines that often can be gravity dependent. As I'm like going through and looking for A lines versus B lines, I often try to clock in my mind for later, like whether they seem to be prominent at the bases or whether they seem to be diffuse throughout, and that can give you some clues. You should see normal lung slidings, and then obviously, depending on the severity, you might see bilateral pleural effusions. We didn't specifically talk about ARDS, but obviously ARDS is an inflammatory alveolar filling process. So you should see bilateral B lines. And then because of that inflammatory process, you might either have normal or reduced lung sliding. And again, it's going to be the cardiac function and whether evaluating for cardiogenic pulmonary edema when you're thinking about ARDS, when you think about the ARDS criteria. So that is the modified blue protocol. And if anyone has any questions, I'm able to see the chat. So feel free to toss them in and I'd be happy to answer. But now we're gonna move on to review some of the basics of a cardiac point of care ultrasound, which may be just review for folks who've done heart ultrasound before, and then talk about something that was new for me that I learned about in the ultrasound elective, which is methods to obtain more objective measures of cardiac function. So briefly, the four kind of general cardiac views that we get in point of care ultrasound, there's the parasternal long axis, the parasternal short axis, the apical four chamber, and the subxiphoid view. We're going to focus specifically on these first three in this review because that'll be what we use to get these more objective measures of cardiac function. And just for the sake of time, didn't specifically talk about the subxiphoid view. But the first view that we often get when doing cardiac point of care ultrasound is the parasternal long axis. So how you'd obtain this somewhere around the fourth intercostal space. Sometimes you have to move it up or down depending on the patient's anatomy, kind of just lateral to the sternum. And then you'd have the probe marker towards the patient's right shoulder. And so with this view, you're kind of cutting the heart, and in an oblique view, you'll see the right ventricle up top. You'll see the left ventricle deeper to it. You'll see the aortic valve if you get a good image in the aortic outflow tract. Then you'll see the left atrium and the mitral valve feeding into the left ventricle. And then you'll see the pericardium as well. So this is a good view to evaluate for potential pericardial effusions. And then if you just rotate the probe 90 degrees clockwise from your parasternal long axis, so now the probe marker would be pointing towards the left shoulder, you can get what's called the parasternal short axis view. And there's three different levels that you can cut the parasternal short axis. This is the view we're going to be using when we talk about the objective measures of cardiac function. So this is kind of the view that's most towards the base of the heart, and it's the left ventricle papillary muscles, and then the right ventricle kind of overlying it. If you rock the probe a little bit cranially towards the head, You'll then get further up in the left ventricle and see the mitral valve appear here. It looks kind of like a fish's mouth. Then if you go even further towards the head, you'll start to catch the aortic valve as well. It'll appear right here and almost look like a Mercedes-Benz symbol. But for what we're going to talk about later, this kind of capillary muscle level is what you're going to want to try to get. And then the last of those basic views that I'll talk about is the apical four-chamber. This is, I think, probably the prettiest view of the heart, but for me has often been the most difficult one to obtain. Um, Often, how I've been taught to do it is feel for the point of maximal impulse. You'll have the probe marker still towards the patient's left shoulder, and then kind of try to find the apex and open it up so you get these nice view of the both ventricles, the mitral and tricuspid valve, and the left atrium and right atrium. And so before I took the ultrasound elective, I knew I felt like I could pretty consistently get the parasternal long axis in most patients. And when I was thinking of how's the patient's cardiac function, the question I would ask myself is generally like, how does the squeeze look? Which is obviously a pretty qualitative assessment. And so things you can look at in doing a qualitative assessment of someone's left ventricular function is like how close are the left ventricular walls coming together? Do they generally seem to be squeezing well? Then we'll talk about this more in depth, but you can look at this anterior mitral valve leaflet and like how close is it coming? Does it seem to get close to that septum during systole, or in, say, the case of a significantly reduced EF, does it kind of stay pretty far away from that septal wall? And I think it's important to note that in experienced point of care ultrasound providers, there's pretty good data that they are relatively accurate in assessing someone's EF on kind of a general level just by looking at it. For someone like me, though, who is still learning, kind of still developing my POCUS skills, I felt like this was often tough. I'd say like, oh, the squeeze looks generally okay, but in kind of those outside those extreme levels, I found it tough to say like exactly how does it look like their left ventricle is working. This is three examples here, which is kind of some two of the extreme ends and then one normal. You can see in a hyperdynamic EF, the like left ventricular walls are coming together. The anterior mitral valve leaflet seems to be almost touching this interventricular septum during systole. And then kind of comparing it to this severely reduced EF, I think if any of us saw this, we'd be like, oh yeah, heart isn't squeezing well, and we need to worry about kind of a heart failure reduced ejection fraction and maybe be more judicious in our fluid resuscitation or take into account what Elena just taught us about cardiogenic shock. But you can see this left ventricle is barely squeezing. The mitral valve seems like it's barely opening. And so those could be some more general assessments. But again, for me, as I've been learning, it's always like I never really knew what to do with this outside of the extremes. And so now I'm going to talk about some objective assessments of cardiac function that are pretty easy to obtain if you are able to get the views and can give us kind of a more objective measure of whether their left ventricular function is normal or abnormal. The first one that we'll talk about is called E-point septal separation. So this is, like I mentioned, used to estimate their LV function. We'll obtain it in the parasternal long axis, and then we'll use M mode to track the motion of that anterior leaflet of the mitral valve throughout systole and diastole. So this is just a brief video here. And so you'll see parasternal long axis. You'll want to try to get this interventricular septum as flat as possible because if you're like at an angle, it will obscure your readings. And then you place M mode, and then you place the M mode cursor right at the distal aspect of this anterior mitral valve leaflet. And then once you activate M mode, you'll start to see a graphic representation of the movement of this mitral valve leaflet over the course of systole and diastole. And so the image on top is kind of a drawing representation of it. And you can see here that what we're calculating here is how close does this anterior leaflet of the mitral valve get to the interventricular septum. And so this is the EPSS value, this reading right here. It's pretty small on this drawing, but as you can see in most patients, there's kind of a more significant distance to measure, which makes the measurements a little bit easier. And so you have that number, and what does it mean? And so there's a lot of different studies that have looked at EPSS and kind of the POCUS literature and what our cutoffs should be for what's a normal EF and what's a reduced EF. This is the values that Dr. Shepard taught us in the ultrasound elective. And in reading through some of the literature, I think this makes 100% to use as the EPSS interpretation. I think there was a helpful study. It was back in 2022, and it was a retrospective study of 96 patients. Just under 50% had HFrEF with an EF less than 40, and 60% had heart failure, mildly reduced ejection fraction. And I think what was helpful in this study is that the point of care ultrasound was just performed by an attending internist. So one of us when we're an attending with no formal training, and then they compared it to a formal echo by a cardiologist. And what they found is using a cutoff of 9.5 millimeters had a sensitivity of 91% for getting an EF of less than 40% and a specificity of 80% with a positive likelihood ratio of 4.7. For like that mildly reduced EF range for an EF of less than 50%, the sensitivity was a little worse, understandably, with a sensitivity of 80% and a specificity of 91%. But what it showed is that using an EPSS and kind of a not internist without formal training, using kind of 9.5, 10 millimeters was a pretty good cutoff, or 9.5, 10 millimeters was a pretty good cutoff in evaluating for someone with a reduced EF. There's some like other data that have used 7 and had okay results. But that's really why 7 to 10 I think of as kind of the unclear range. Less than 7 I think you can confidently say that patient probably has a normal EF, and then greater than 10 is where you really need to start worrying about the patient having a reduced EF. And so the next objective measure of cardiac function that we'll talk about is called fractional shortening. You can actually get this in either the parasternal long or short axis. I was taught to do it in the parasternal short axis. And so this is what I'll often do. And sorry, I should have mentioned, thinking of confounders for this, the EPSS, there is, you can think if a patient has mitral valve disease, that'll confound the EPSS. So that's something to keep in mind, especially if a patient has a prior echo with mitral stenosis. You can think the mitral valve inherently has an issue. And so, whereas they might have an elevated EPSS, it could just be a mitral valve problem as opposed to a reduced EF problem. And so, that's something you need to consider as you're interpreting this, which is, I think, it's sometimes helpful to do both of these studies because they can have kind of different confounders. And so the next one is called fractional shortening. And again, this is an estimation of your left ventricular function. You'll use M mode again to obtain this. And so what you'll do is you'll get the parasternal short axis view at that mid-papillary view, and then you'll do M mode kind of right down the middle. And so what that will graph for you is the movement of the ventricular walls throughout diastole and systole. So you can see up top, you'll see the intraventricular septum. Down below, you'll see the LV posterior wall. And then there's a pretty quick calculation you can do using the diameters of end diastole. So when the ventricle is at its widest and end systole to get what's called a fractional shortening percentage. And so it's important to note that the fractional shortening percentage isn't equivalent to the EF. This is kind of a chart. Most of this data is actually from kind of formal, the American Society of Echocardiography and the European Association of Cardiovascular Imaging is the people who came up with these cutoffs. But I usually think of if it's greater than 25%, then they probably have a normal EF. Kind of that 20 to 24% is mild, 15 to 19 is moderately, and then kind of less than 15 is severely reduced. And again, just like with the EPSS, there's potential confounders of this. You can think of, say, if a patient has a prior MI and has a focal wall motion abnormality, then that might kind of underrepresent the EF because it's just that one wall that's not moving, where the remainder of the left ventricular walls are able to move appropriately. But I think this is just a helpful another method to get a more objective assessment of a patient's cardiac function. I think in looking through the literature, there's less literature on fractional shortening and like the internist without formal training. I was able to find a lot better literature in that on EPSS. So I'll often do EPSS first, and then we'll do fractional shortening in addition if I'm able to get a good parasternal short view. And I think like as I'm learning, it's been helpful for me to kind of see like um because inevitably this shouldn't replace a formal echo. It's kind of just in the immediate sense. So then I can take my initial evaluation, compare it to a formal echo, and start to learn a little bit more and kind of get a better sense of how accurate I am with this, because it's obviously something that takes practice. And so the last thing that we'll touch on is TAPSE. Some of you may have heard of this before, but as opposed to our first two, which are looking at the left ventricle, this is looking at the right ventricle. And this is again using M mode, looking at the distance, looking at this tricuspid annulus here, so where the tricuspid valve meets the right ventricle. And it's essentially looking as how is that tricuspid annulus moving through diastole and systole, or like how is the right ventricle squeezing? And then you calculate kind of the total distance that it moves. I think we use this most often clinically in thinking about RV strain in the setting of, say, submassive or massive pulmonary embolism. And the kind of general agreed upon interpretation is that a TAPSE less than 17 millimeters is concerning for RV strain. There has been a lot of different studies on TAPSE, and in the absence of other hemodynamic signs of a pulmonary embolism like hypotension or tachycardia, it's not a great study, 72% sensitivity and specificity of 66%. But in a patient with tachycardia and or hypertension, or hypotension, excuse me, the sensitivity of TAPSE alone increases to 94%. So if you're able to get a good apical four-chamber view, it's kind of a good immediate assessment to see if they have right ventricular strain, if they have a known pulmonary embolism, before you're able to get some of the other kind of labs or formal studies back to evaluate for that. It might help guide your initial management. So, in summary, the modified blue criteria can be used in our diagnostic assessment of lung pathology. We look for lung sliding, we look for A lines versus B lines, we look for consolidations, and we look for pleural effusions. And then EPSS and fractional shortening are two objective measures of LV function that can be obtained via POCUS. And then we can think of TAPSE for RV strain. And I think it's important to say that our point of care ultrasound shouldn't be a formal replacement for some of the more formal studies, like a formal echo. But I think, if you're overnight or on the weekends when, say, you might not be able to get a formal echocardiogram, I think it can help in kind of guiding your initial management while you wait for those studies to come back, and also help guide further workup and think, well, should I get a formal TTE, or do I need to get more advanced lung imaging as we think about kind of the pathologies that our patients have. And then finally, just a quick plug. I think you should have all gotten a reminder email yesterday, but I'm working with Ann Jenrick in the pulmonary critical care department to look at moral stress, burnout, and coping strategies among residents. So there's a brief survey that was sent to your email, and I would greatly appreciate it if you could all fill it out when you have a chance, maybe in the break before these next lectures. But that is all I have, and thank you for your time. I'll open it up to any questions if anyone has any.
Hi. Hi.
Hi.
Hi.
Sharon, thank you so much. This was great. I have
Yeah.
to say in the chat, I've got a couple requests for your slides as well.
Yeah.
I think this is so empowering to us as internists to have some tools and some like more objective things than rather just like eyeballing and being like, hey, I think this is what's going on with the heart squeeze, or I think this is what's going on in terms of like a reduced or hyperdynamic EF. So thank you for that as
Yeah.
well.
Yeah. I know, like in myself, I did a rotation in Livingston, Montana last month where we had much less access to kind of formal echo studies, and was able to have a patient with unknown hypotension, found that they had like a severely reduced EF, and then uh, ended up diagnosing them with cardiogenic shock, which was kind of a cool putting into practice.
Absolutely. Got a lot of uh, cheering things in the chat as well.
Come on. Come on.
Awesome. Thank you.
All right, I'm gonna mute. We'll start back up at 10:45.